Pancreatic and duodenal injuries are more common following penetrating trauma. However, a high index of suspicion must be maintained in blunt trauma with a direct blow to the epigastrium, such as with a bicycle handlebar, steering wheel, or seatbelt. These injuries can crush the pancreas against the vertebral column or injure the duodenum by rapidly increasing intraluminal pressure. The presence of free air or fluid in the retroperitoneum should raise suspicion for an injury. However, these findings may often be subtle and missed. Patients with duodenal hematomas may present with symptoms of obstruction with associated findings on CT. Duodenal hematomas are managed with conservative or non-surgical management with nasogastric decompression and parenteral nutrition. The majority of duodenal injuries are treated with debridement and primary closure when possible. Primary repair is appropriate for partial or complete transection of the duodenum if there is little tissue loss, the ampulla is not involved, and if the mucosal edges can be debrided and closed without tension. Primary repairs can be buttressed with an omental or serosal patch. A closed suction periduodenal drain can be placed as a controlled fistula will ensue in the event of a suture-line dehiscence. If adequate mobilization for a tension-free repair is impossible, or if the injury is near the ampulla and mobilization risks common bile duct injury, a Roux-en-Y jejunal limb anastomosed to the proximal duodenum at the site of injury is a reasonable option. A less desirable approach may be the jejunal or thal patch repair, whereby the serosa of an adjacent loop of small bowel is sutured as a buttress over the duodenal defect. This technique has been fraught with complications and is not recommended. Duodenal diversion should be considered in situations when the duodenal repair is tenuous or in the presence of combined pancreatic and duodenal injuries. A pyloric exclusion is performed through a gastrotomy and consists of grasping the pylorus with a Babcock clamp, suture closing the pylorus with absorbable suture, and construction of a loop gastrojejunostomy. The gastrojejunostomy diverts gastric flow away from the duodenum for several weeks while the duodenal and pancreatic injuries heal. The pylorus eventually opens and the gastrojejunostomy functionally closes. Pancreatic injuries should be suspected following a similar mechanism as duodenal injuries. Imaging may demonstrate parenchymal disruption, intrapancreatic hematoma, fluid in the lesser sac, or peripancreatic edema. Injury presentation may be delayed, and because these injuries are retroperitoneal, they do not result in a positive FAST. Grade 1 injuries consist of minor hematomas or superficial lacerations without duct injury, whereas Grade 2 injuries are major contusions or lacerations without duct injury. Grade 3 injuries are distal transections or parenchymal injury with a duct injury. Grade 4 injuries are proximal transections or lacerations with ampulla involvement. Grade 5 injuries are massive disruptions of the pancreatic head. Pancreatic injuries not involving the duct, such as Grade 1 and 2 injuries, can be observed or, if identified during laparotomy, managed with wide closed suction drainage. Distal transections or lacerations involving the duct can be managed with a distal pancreatectomy. Proximal injury should be managed with wide drainage, as these patients are often unstable. After closed suction drainage, diagnosis of a pancreatic fistula is confirmed if the drain amylase is at least 3 times the serum amylase. A management plan for pancreatic fistula includes observation, enteral feeding distal to the pylorus, and serial monitoring of drain output quantity and amylase content. Persistent high-output fistula drainage despite conservative management is an indication for ERCP and possible pancreatic duct stenting if an injury is identified.